Okay, I think I am live. Let me see if the thing is live is starting, and I'm now live. Hey, this is Elliot Fishman. Hello, and hope everybody is doing well. It's Friday, it's the 29th of May. I worked last weekend, I worked next weekend. I'm not working this weekend. I'm in New York actually. You can see because I'm with one of my friends. Here's Bamba. Right? Okay, say hi, Bamba. Okay. And Bamba's going to help me give this talk. Um, I was at the inaugural event for the Blank Foundation on pancreatic cancer. They're from Long Island here, and basically they're going to help support our research at Hopkins. So that's very exciting. It was a real honor being there last night. A really very, very nice event. And so I'm here for just a couple of days and going back home. The topic of inflammatory bowel disease is one that we spent a lot of time writing about. I remember I must have written 10 articles or more on Crohn's disease, CT of Crohn's disease, way back when. One of the applications that's always been a challenge is the evaluation by Bamba of inflammatory bowel disease. And, we talked about fluoro, that was the classic thing. And then CT came along, and CT became the ideal study. And when we talk about inflammatory bowel disease, in my mind, I typically think about Crohn's disease. We talk about involvement of small bowel, we talk about involvement of large bowel. But we see lots of inflammatory bowel disease involving many things. Today's Friday. On Wednesday, I do conference for the fellows and faculty, and I was showing cases, and I remember I was quizzing Linda Chu, and like one case was graft versus host disease. One was immune checkpoint inhibitor related disease. One was related to HIV and MAI infection. One was related to ACE inhibitors. So there's lots of diseases that can affect bowel. They can look very similar. Clinical history is very important. If a patient had a bone marrow transplant, you see really thickened small bowel, prominent vasa recta, maybe some large bowel involvement. It's not that hard to say graft versus host disease because bone marrow transplant, that's what you think about. Or it could be infectious because patients are immunosuppressed, can get infectious disease. If somebody was treated with melanoma, immune checkpoint inhibitors can give you GI bleeding, they can give you inflammatory bowel disease. Again, the clinical history becomes very important. If a patient was given had hypertension, was given some new drug, an ACE inhibitor, and they were given it yesterday, and today they were having an acute abdomen, really thickened bowel, then it's related to the medication. If a patient has really thickened bowel and it looks inflamed, then you can even think about Crohn's. But the patient's getting radiation therapy for rectal cancer, cecal cancer, or anything, and it kind of matches the field of view, it's easy to say this is probably radiation enteritis. We talk about other things, abdominal pain, we talk about Crohn's disease. Crohn's is probably the thing we think about most. Narrowing of the terminal ileum typically, though Crohn's can involve everything from the stomach through any of the bowel, TI. You'll also see involvement by the ileocecal valve. You have prominent vasa recta. Patients with Crohn's disease also develop prominent fat around the bowel. Fibrofatty proliferation of the mesentery is typically how we call it. And so that becomes a very important thing. Limitations in terms of technique is very important. Giving positive contrast, we used to do that and wait hours. We use water, that works very nicely. Things like CT enterocolitis, which is an oral agent, which brings fluid into bowel, distends the bowel, and then you give IV contrast. I typically like dual phase imaging. That indeed works very nicely as well. And then you could pick up areas of strictures, areas of inflammation. One challenge, of course, is, at least in theory, and more than theory, in fact, patients with long-standing IBD can develop carcinoma, an increased incidence, and sometimes it's tricky when you have a subtle cancer which presents with a stricture and differentiating that from a stricture in a patient with inflammatory bowel. So it kind of becomes somewhat tricky. Technique is really everything, lots of water or any of these agents that you could use that are sold that bring fluid into bowel works really well. As I mentioned, I always do IV contrast because things like the vasorecta, things like bowel enhancement, whether it's increased or decreased bowel enhancement, those are things that are better seen when you're able to give IV contrast than doing a water-only study, which I don't particularly like. So that works out very nicely. I do like to, of course, not just look at the images in the axial plane, but coronals and sagittals. Sagittals mainly for the vessels. Coronals are really a good way of following bowel. And kind of going back and forth really makes things a whole lot better. So I really do like to do that. I'll be very careful, particularly in the right lower quadrant. I'll target the images. And again, looking for any fissures, looking for stenosis, looking at the vasorecta are all things we do. Again, we would consider or at least think about patients with long-standing disease. You want to make sure you're not missing a cancer. It's infrequent, but you want to look carefully. We talk about inflammatory bowel disease involving the large bowel. With Crohn's, it's terminal ileum and cecum, but you can see skip areas. We can talk about ulcerative colitis, which is mainly large bowel. Can be large segments, can be a pancolitis, the entire bowel, can be just simply the rectum and sigmoid colon. Ulcerative colitis typically contiguous. Crohn's is more commonly has gaps in the area. So it's very important. It's an important part of CT. On CTisus, we have a lot of cases. You can look at those. I have the protocols online. We also have a bunch of lectures on inflammatory bowel disease. You could look at those as well. So let me see if I can recognize, let me see if anyone, there's a bunch of people online, but since Facebook changed things, it's always a touch tricky being able to see them. Anyway, so those are the main things, and hopefully you find that helpful. And I mentioned it's Friday, and I hope everybody has a great weekend, and I'll see you soon. Bye, guys.